the Residence Corner module. These sessions are arranged by the Department of Neurosurgery at Liaquat National Hospital. And the idea behind these sessions is to build 3D neuroanatomy, which is very important and eminent for while performing any neurosurgery. The topic of our presentation today is the anterior cranial base. Dr. Amna is first year resident at Liaquat National Hospital. Our expert panelist today is Professor Khalid Mehmood. Professor Khalid Mehmood is Executive Director and Head at Pakistan Institute of Neurosciences with special interest in endoscopic skull base. Professor Mehmood, it's an honor to have you, sir. And you have Professor Khalid Mehmood, sir, it's an honor to have you, sir, and you have joined us before, and that shows your commitment towards education of neurosurgery in Pakistan. Dr. Amna, can you start?
Yes, sir. Assalamu alaikum. My name is Dr. Amna. Topic for my today presentation is anterior cranial base. As we all know that cranial is divided into the calvarium and the cranial base, and the cranial base is further divided into the endocranial surface and the exocranial surface. The endocranial surface, which faces the brain, and the exocranial surface faces the nasal cavity, sinuses, orbits, pharynx, and the infratemporal and the pterygopalatine fossa. As you can see that the anterior cranial base is divided from the middle cranial base by the sphenoid ridge and the chiasmatic sulcus. And the middle cranial fossa is divided from the posterior cranial fossa by the petrous ridge and the clinoid process. And on the anterior, the exocranial surface of the anterior cranial base is divided by a transverse line which passes from the pterygomaxillary fissure up to the posterior edge of the alveolar process of the maxilla at the lower level. The anterior skull base is formed at the medial part by the ethmoid bone anteriorly and the sphenoid posteriorly. And on the lateral side, it is formed by the frontal bone and the lesser wing of sphenoid. On the endocranial surface, as we can see, there is foramen cecum, from which the emissionary veins pass, and the cribriform, which is a part of the ethmoid bone from which olfactory nerves pass. The mid portion of the ethmoid bone is the crista galli. On the endocranial side, the medial part of the anterior cranial base covers the nasal cavity, and on the lateral side, it covers the orbit and the maxilla. The anterior cranial base faces the frontal lobes, in which the gyri recti form the medial part, in which the gyri recti form the medially, and the gyri orbit from the lateral wall. And the anterior cerebral artery is in relationship with the medial side of the anterior cranial base, and the medial cerebral artery is relationship with the lateral side of the cranial base. And another important foramen of the anterior cranial base is the optic canal, from which the optic nerve travels along with the ophthalmic artery. Now, this is the schematic diagram of the sphenoid bone. So to understand the anatomy of the better, this is the lesser wing of the sphenoid, along which is showing the anterior clinoid process and the chiasmatic circles. Anterior to chiasmatic circle is the boundary of the anterior cranial fossa, and posterior to the chiasmatic circles is we have the hypophysis pituitary gland, which lies in the middle cranial fossa. This is the ethmoid bone, which forms the medial part of the anterior cranial fossa. Ethmoid bone have the perpendicular plate and the lateral plate. The perpendicular plate form the roof of the nasal cavity, and the lateral plate which separates the orbital cavity from the nasal cavity. This is the another view of exocrine surface in relation to the anterior cranial face, as we have known that medial side is formed by the sphenoid sinuses and the lateral it is formed by the orbit. Now we will discuss regarding the anatomical of the orbit. The orbital roof is formed by the lesser wing of sphenoid and the frontal bone, and the lateral part of it is formed by the zygomatic bone and the greater vein of sphenoid. Inferiorly, it is formed by the zygomatic, some part which is formed by the palatal bone. Here it is not shown, and the maxillary bone and the zygomatic bone. On the medial side, it is formed by the ethmoid bone, maxillary bone, and the lacrimal bone. In the nasal cavity, as we look from the inferior side, the ethmoid form the posterior part of the nasal septum, and vomer further form the part of the nasal septum. In this diagram, we are looking at the cranial base from below. This is the maxilla, which form the maxilla, and the part of the palatal bone which form the hard palate. On the lateral side, we have the maxilla and the zygomatic bone. The zygomatic arch is formed anteriorly by the maxillary by the zygoma, and posteriorly it is formed by the temporal bone. The other schematic views which we have discussed previously regarding the floor of the orbital wall, which is formed by the palatal bone at the medial side, and the maxillary bone and the zygomatic bone. And laterally it is laterally, as it is shown, it is formed by the zygomatic bone. This is a view showing of the nasal cavity from the medial side, in which we can see that the ethmoid forming the superior part of the nasal septum, and inferiorly it is formed by the vomer bone. Other foramens which are important in this is the anterior and the posterior ethmoidal foramen, which we will discuss later on. This is the lateral view of the skull, which is showing the base from anterior up to the posterior. Anteriorly, in the base, we have the maxilla and the temporal bone, and it is up to the occipital bone. This is a keyhole which is formed by the frontozygomatic sulcus. The importance of keyhole here is at its gives entry point to the both anterior, middle, and the orbital base. Here we can see that it is the frontal process of the zygomatic bone, and the laterally it is a zygomatic bone, which or joined by the petrous bone to form the zygomatic arch. This is another view from the inferior side, in which we can see the ethmoidal air cells has been exposed. The inferior wall of maxilla has been dissected to show the superior part of the maxilla, which is forming the floor of the orbit. This is the vomer bone, which is forming the on the medial side. The anterior cranial base is restricted at the level of the vomer. On the lateral side of the sphenoid, we have the pterygoid, which is a part of a sphenoid bone, which forms the medial boundary of the pterygopalatine fossa. There is another diagram from showing inferior side. In this, a part of the maxilla and the palate have been removed, and the part an inferior wall of the orbit also had been removed, but superior part of the frontal bone is remained. This is the greater wing of a sphenoid, which is forming the lateral part of the orbital wall. This is the inferior orbital fissure. On the right hand side, there is this is the anterior view, which is showing the ethmoid air sinuses and the supraorbital foramen from which the supraorbital nerve pass. The orbits in the orbit we have superior orbital fissure, which opens into the middle cranial fossa, and orbit opens into the into the pterygopalatine fossa via the inferior orbital fissure. There is another view of showing the inferior orbital fissure and the relationship of pterygomaxillary fissure along with the infratemporal fossa. As you can see, this is the temporalis fossa, and below the zygomatica we have the infratemporal fossa. And medial to it, there is lateral to the pterygoid plate, we have pterygomaxillary fissure, which opens into the pterygopalatine fossa. This is another view of the maxillary sinus, in which the anterior and posterior wall of the maxillary sinus has been removed to show the anterior boundary of the infratemporal fossa, in which the superior orbital fissures have been seen and the foramen rotundum have been seen. From foramen rotundum, the maxillary branch of the trigeminal division passes. There is a schematic diagram to show the to show regarding the proper orientation regarding the pterygopalatine fossa. As we can see that we are viewing from the lateral side, and this is the infratemporal fossa. The infratemporal fossa open into the pterygopalatine fossas, which again open into the sphenopalatine foramen. And from anteriorly, this areas, as we can see, that this is the sphenoid bone. This is the later pterygoid and medial pterygoid. And this is and the along with the pterygomaxillary fissure, we can see that the sphenopalatine artery passes and it's open medially into the sphenopalatine foramen. There is another diagram in which a part of the maxillary sinus, the lateral wall anterior have been removed, and only the medial part of the palatine bone and maxillary sinus is placed. And on the orbital cavity, superior orbital fissure and the greater wing of sphenoid has been remained. As we can all see that, and the anterior cranial base, laterally it is formed by the frontal bone, which forms the superior boundary of the orbital roof. This is another diagram in which the maxillary sinus posterior wall has been intact, anterior wall has been removed, to show the proper orientation regarding the infratemporal fossa and the pterygoid process. This is the greater wing of sphenoid, and this is a frontal bone. Same, there is another the same which angle in which we can see that the apart from the ethmoid cells has been removed, and to show us the optic canal and optic strut, and which is separated from the superior orbital fissure. And This is from the anterior side. As we can see, this is the from the anterior side. As we can see that this is the part of the sphenoid bone in which pterygoid process and pterygoid palate has been shown. And here in the nasal cavity, in which we can see that the palatal bone and herb has been placed. On the lateral side of the maxilla has been removed to show us the boundary of the infratemporal fossa. Osseous anatomy can be discussed. Now we will discuss regarding the anterior cranial base structures other than the osseous. This is the superior view, which is showing in the left side the maxilla. The part of the maxilla had been removed. As we can see that this is the anterior ethmoidal cells which have been shown. In the anterior cranial base, you can see that medially it is formed by the it is formed by the ethmoid and the sphenoid side, and laterally the anterior cranial base has relationship with the orbit and the maxilla. Here you can see on the lateral side the maxillary region of the trigeminal nerve, which is exiting into the foramen rotundum and entering into the infratemporal fossa. This is the superior view of the same diagram, which is showing the better relationship of the anterior cranial base in with the orbital roof. And on the left side, the orbital roof have been removed. The part of the superior part of the maxilla have been removed, which is showing the inferior part of maxilla. And medially, we can see that these are the ethmoid sinus, which is showing the nasal cavity and the part of a nasal septum. And laterally, we have the ethmoid sinuses. Another view to understand regarding the anatomy of the exocranial surface, in which we can see that the part of the maxillary sinus has been removed and anterior boundary of the sphenoid has been removed to show the sphenoid sinus and the sella. And the maxillary sinus anterior boundary has also been removed in this, and a part of orbit has been removed. And the orbital apex has been visualized in this diagram. And as we can all see that the right maxillary sinus, which is formed the floor of the orbital wall, and the nasal lateral wall, which is formed by the nasal cavity, and the anterior wall of which is formed by the pterygopalatine and infratemporal fossa. And on the left side, as you can see that the mandibular branch of the maxillary of the trigeminal nerve is entering into the infratemporal fossa. And this is orbital apex, which has been shown above. Another diagram in which we can see the relationship of optic nerve along with superiorly by the frontal branch of the ophthalmic nerve, which is passes superiorly to the optic nerve. And inferiorly, we can see the maxillary sinus. And the inferior part, in the nasal cavity, this which is exposed, this is showing the nasolacrimal duct. Now we will discuss regarding the endocranial surface. Now we are viewing from above. In this diagram, frontal bone has been removed. On the medial side, we can see that the ethmoid bone. And on the lateral side of the ethmoid, we have the cribriform plate. The frontal bone anteriorly divided to form the frontal sinus. In the diagram, we have removed the periorbital fat to better visualize the anatomy, in which we can see that the frontal nerve of the ophthalmic division has been shown, and the trochlear nerve, which is showing from the lateral side, and it is traversing from lateral to the medial side to supply the superior oblique muscles. Another magnified view of the same diagram and which more dissection of the periorbital fat, as we can see that this is the optic canal and this is the annular zinc. We can see that the frontal nerve traversing from lateral to the medial side and trochlear nerve is traversing from the lateral to the medial side to supply the trochlear nerve, superior oblique muscles. In this view, as we can see that the superior rectus muscle and the ophthalmic branch is traversing superiorly to the superior rectus muscle. And in this view, we can see that the superior oblique muscle is supplied by the trochlear nerve, and these are the nasociliary nerve, which is on the medial side of the optic on the orbit. In this view, superior oblique muscle is retracted to better visualization of the anterior ethmoidal and the posterior ethmoidal artery and nerve, which are supplying their foramen. And the frontal nerve is further divided into the supraorbital and supratrochlear anteriorly. Here, superior oblique muscles is retracted for the better visualization of the nasociliary nerve and the ophthalmic artery, which is on the medial side at the and which is anteriorly, which is on the medial side of the orbit, and afterward it traverses on the lateral side of the orbital canal. There is the same view, which is further showing the ophthalmic artery, optic nerve, and frontal nerve as it is passing from the superior rectus muscle into the laterally. In this view, optic nerve has been retracted to better visualization of the ophthalmic artery, as we can see that at the level of the apex, optic artery is laterally and afterwards is traversed more towards the medial side. Here in this diagram, the foramen rotundum has been shown, in which the maxillary division of the trigeminal nerve is passing. This is the same diagram which as we have seen before, and we are looking from superiorly, periorbital, some fat had been removed, and this is showing the anterior. On the medial side, as we can see, we have olfactory nerve, which lies above the cribriform plate of the ethmoid bone, and laterally we can see that some part of the orbita has been removed to show the frontal nerve and the nasociliary nerve. In the same diagram, other part of the periorbital fat have been removed to show the better anatomy of the superior oblique muscle, ophthalmic artery, and the abducens nerve. In this diagram, both the orbital content had been removed to show the better anatomy of the orbit floor, in which we can see that inferior orbital nerve and inferior orbital artery is traversing. This is again showing the diagram which we are from the superior side. In anteriorly, we have the sphenoid planum, and the laterally we have the orbital apex, and the posteriorly this is the chiasmatic surface, and the pituitary strong, which is lie posterior to the anterior cranial base. This is a diagram which is showing the sagittal relationship of the anterior cranial base, in which we can see that the anterior part, in which we can see that the lateral wall of the nasal cavity is formed by the sphenoid bone and the sphenoid bone, which contain the superior turbinate and the middle turbinate. The inferior corner or the inferior turbinate is the separate bone. In this diagram, most of the mucosa of the superior, middle, and inferior turbinate have been removed for the better visualization of the superior orbital fissures. This is the part of the lateral side in which we can see that the cribriform plate has been showing above, is showing the olfactory bulb, and inferiorly it is showing the maxillary sinus and the frontal sinus ostium, which is open into the nasal cavity. This is the rosomillar fossa, from where the inferior side the nasal lacrimal duct open. On the more lateral view, as we go from medial to the lateral side of the sagittal view, this is the maxillary sinus, which has been shown below. Superiorly, we have the orbit and the part of the periorbita, which has been shown here. Here we can see that the optic nerve is passing, and the inferior orbital nerve. In this view, other than optic nerve and extraocular muscle and the content of orbits are shown along with the anterior cranial base with the frontal lobe. In this diagram, the lateral wall of the maxillary sinus has been removed to show the better anatomy of the inferior, the pterygopalatine fossa and infratemporal fossa. This is a sagittal view showing in relationship in which we can see that in the nasal cavity we can see middle turbinates and the inferior turbinates, and on the lateral side it is formed by the maxillary sinus. Superior to it we have the orbital cavity, and on the roof of the nasal cavity which is formed by the ethmoid sinuses. More anterior view of the sagittal of the coronal plane section of the same, which is showing that the inferior meatus in the inferior turbinate and middle turbinate. As we can move further backward on the same coronal section, we can see the optic nerve, and laterally we can see the extraocular muscles and ophthalmic artery. Inferior to it, we have maxillary sinus, which has been shown here, and later and the part of a pterygo, and lateral to the posterior to it, pterygopalatine fossa. Same diagram in which other structures have been visualized along with the optic nerve and foramen rotundum, from which we can see that the maxillary division of the trigeminal nerve passes, and the maxillary artery, in which its terminal branches lie towards the sphenopalatine artery towards the pterygomaxillary fissure. Again, this is the same diagram showing from the inferior side, which we have discussed previously regarding in the sphenoid bone to show the Vidian canal, and the pterygoid process have been removed in this diagram. The same as we are viewing from the inferior head side, you can see that the ethmoid sinus has been exposed, and posterior towards we have the vomer bone, which form the posterior boundary of the nasal septum, and lateral to it we have the maxillary sinus, and which is forming the lateral boundary of the orbit, and lateral to it we have the greater sphenoid ring. This is the diagram as we are seeing from the inferior view of the middle turbinate, and these are the gestational tube which open into the pharynx, and this is the rosomillar fossa, which we have been seeing the transverse view of the where the nasolacrimal duct open. On the lateral side, we can see that the maxillary artery and the carotid is passing. And this is the inferior, and later two is the inferior infratemporal fossa. And the same diagram which is showing the carotid sheet along with the internal jugular vein. Thank you, sir.
Thank you, Dr. Amna, for your presentation and detailed discussion of the bony anatomy fossa. I would now like to invite Professor Khalid Mehmood to give his expert opinions. And if there's any questions in between, the participants are invited to use the chat box. Professor Khalid Mehmood, sir, your expert comments on the presentation and the anatomy of the anterior cranial fossa.
Thank you, Saad. I think it was an excellent overview of anatomy of the anterior cranial fossa by Dr. Amna. Nowadays, you have to learn two types of anatomies. One is a conventional anatomy from above, which we have been studying in anatomical textbooks. And then you have to learn the endoscopic anatomy from below of the anterior cranial fossa. Because a lot of minimal invasive surgery and other surgeries are shifting through the minimal invasive approach through the nerves. So if you go from below, you should be knowing the anatomy from below. So I think you need to learn the anatomy first. So when you know the anatomy, you can appreciate the radiological anatomy, like CT FAS, and then obviously the perioperative anatomy. So anterior fossa is a gateway. Basically, it has got two important bones. That's the ethmoid bone and the sphenoid bones. Although you have got a frontal bone covering the orbital plate, orbit. And it has opening into the orbit, it has opening into the nose, it has opening into the paranasal sinuses. So the micro details of the anatomy of the anterior cranial fossa are very, very relevant when you go endoscopy from below through the nerves. And how you correlate your anatomy with the radiological anatomy is when you learn the anatomy from above and below, I will stress upon all the residents that they should appreciate the CT FAS pictures. It's a functional endoscopic sinus surgery. It's a CT FAS protocol. You just get the bony windows and you get a 0.2 mm or 0.3 mm cuts, and you should be trained to look all these in different views like sagittal, coronal, and axial on a radiant software. So the era of having the hard copies looking on the view box has gone. Now you should have a 300 images of the CT FAS protocol. You should be looking at the minutest details. And the whole idea is that you should very exactly know where is the pathology, where you have to attack anatomically, and what is the pathology. Because nowadays in 80-90% of the cases, there is no surprise. You know where is the pathology, you know what is the pathology, and you pre-plan how to actually reach to that point without disturbing the rest of the anterior fossa or the rest of the brain. So I think you should keep on reading the surgical anatomy from above, from below. Then you should know the radiological anatomy. You should know how to correlate this conventional concept to the modern concept. And then paraoperatively, you should keep on actually correlating your anatomical knowledge, because many times what you read in the books, you don't find paraoperatively, or radiological anatomy is totally different because that goes into the minutest details. So I think it's just a matter of rehearsal. And if you really want to go very advanced from your theoretical knowledge, you should be doing the cadaveric workshops. cadaveric workshops. They're the best way to learn their anatomy from above and from below. And then from these workshops, this one workshop is not enough. Like in 1 year, you should be doing at least 2 workshops. You should be dissecting 2 heads in the frontal, in the sagittal plane and in the coronal plane. And then you would grip, and then you would be able to become a very safe surgeon.
Thank you, Professor Khalid Mehmood, for your expert opinions and your time. Just for the sake of the residents, as Professor Khalid Mehmood said, that we should all be doing workshops. There is a workshop coming, which is arranged by the European Conference of Neurosurgery, and it is in Greece, about the endoscopic skull base. And we always have the Pittsburgh workshop, but this is for the beginners. It's in Greece. It's in October. And it is a nice workshop where they teach you the section on the endoscopic, very big for beginners, endoscopic skull base dissection. So if there's any question by the participant, we'll be happy to take it. If not, then we'll end the session. And I would like to again thank you, Professor Khalid Mehmood, for your time. You have come in time again. We've always bugged you on the 11th hour, but you've never refused, and that shows your commitment towards education in Pakistan for neurosurgery. So if there's any questions, we will take it now. If not, then we will end the session. Thank you, Professor. I don't think, sir, there's any questions. Thank you, Professor Khalid Mehmood, sir, for your time. We would like to have you in the future as well.
Thank you.
Thank you, sir. Thank you, everyone. We'll all see you next week. Please take care of yourself. Take care of yourself. Thank you, everyone.